Okay, so this gentleman has obstructive jaundice. They think it's possibly an ampullary lesion. Okay, so we're in. You can see he's got a malignant obstruction of his intrahepatics. Okay, no focal lesions. Pretty unusual to have focal lesions with an ampuloma. So now I'm going to look at for his pancreatic duct. Okay, we torque. The veins coming out of the liver down here, and there's the malignant obstruction of his PD. So that suggests that it's invading into his pancreas, so it wouldn't be endoscopically resectable. But you can get surprises. Okay, so now we're going to go look at his into the bulb. Okay, into the bulb. We're going to go all the way into D2 right. We can see there's some infiltration or something going on there. Whoa. I'm going to go all the way into D2 to begin with. There we go, shortening up. Can we see his ampulla? There's something there. Doesn't look, it's a little bit abnormal looking, but I'm not seeing the actual papilla yet. Which is right there, so it doesn't look like an ampulloma, as far as I can tell. Okay, so we'll put our tip up. We're up against the wall. So here's the air in D3. This is the pancreas here coming back. So there's the PD coming out of the papilla right there. Okay, so if that's the case, then the stricture has to be much higher up here somewhere. It's going to be around the genu somewhere, because there's his distal body, which is normal too. So we're going to follow them both, and we're going to hit the lesions here, right at the confluence. And you can see that it's kind of partially encasing the confluence right here, which is not good. So I'm going to try and biopsy him from here. You want to be in the bulb in case he gets surgery, because there's a risk of tumor seeding if you go from the stomach. But with this involvement of the confluence here, I think it might be already questionably operable. You can see the pancreatic duct stricture here, and then the obstructed PD above it. So we're going to take a 25 ProCore. You see the dilated duct coming out of it there, dilated bile duct, and follow it down. You want to biopsy right where the stricture is, okay? So once you see the dilated duct coming out here, you turn till it disappears. That's where the money is, right there, okay? Same thing with the pancreatic duct. If you don't see a mass, go right where the stricture is. So here's the dilated duct. It disappears. This is where you're most likely to get the diagnosis. Okay, so the needle's coming out way up here. So I have to pull back here, but the problem here is it's right at the at the juncture. It's at the genu, so like I'm kind of in between the bulb and the, so it'll have a tendency to slip out. I have to get in a good position, but it's hard to get. So see, here's the PD. I want to go right where it disappears, right there. There's the needle. Needle in. Try to go here. Okay, and then again, you want to kind of come out, go somewhere else if you can. It's got a nice blood vessel right in the way there, which is not great. But you see the stricture is right there, and I'm kind of going right where the stricture is. Okay, again, right there. Right there. I'm trying to come out and go somewhere else. There we go. So the multi-pass technique. Okay, and try to find another place here. Right there. Okay, one more place maybe before putting it on the slides. Pancreas. Okay, so that's it. Didn't look like a lot came out on that pass, and so here's probably a better place to biopsy. I'm in the bulb now, and see now I'm really right up against. Here's the stricture. Here's the lesion right here. This is a better position. And as I say, I think it's always good to biopsy in more than one from different positions, because it's kind of like imaging. You get different sampling of the lesion, I think. Okay, so there. So again, there's the PD stricture right. There's the duct. It disappears. That's where the money is, right there. Okay, and if I go left, you'll see the dilated bile duct coming out of the lesion right here. Okay, but I think you want to focus more on the PD stricture, because that's usually where the tumor is. The bile duct stricture is less less important. Putting the needle out over the sheath out over the elevator. There we go. Okay, there's a nice blood vessel in the way there again. In we go, right there. I'm not showing you the needle tip very well, so I'm going to pull out a little bit and do it again. Yeah, there we can see it. We're in good position there. Okay, back and forth. Okay, there we go. There we go. Okay, so this should be enough. So now we have definitely more blood anyway, but there should be more material as well. Okay. You can see there's a little bit of interaction with the duodenum here as well, which we saw endoscopically. And here's the part where the lesion is kind of touching the confluence, I think. But it shows where you really have to look in different zones. Right there, okay, right there. So I'm having somebody hold the scope because it was tending to fall out a little bit, which was not helping in the first place. So there's the needle right here. Okay, there we go, in we go, suction. Then I'm going to come out, go somewhere else if I can, moving the elevator. Okay, coming out, torquing a little bit to get in a different zone maybe. Kind of more here. There we go. This is a different area. This is a different area. Okay. Just really trying to sample all through this to maximize the chance of getting cells from, what's really going to be tumor. Okay. Okay, so basically a genu lesion with a little bit of duodenal involvement. Partial encasement of the confluence that you see only really from when you're coming back from D2, which shows that it's important to look at these lesions from as many different perspectives as possible. Because I'm coming back from D2 here, and here it's here that you see there's just this partial encasement, I think, of the confluence. He's going to go to ERCP now, and then the surgeon will decide whether they want to take him straight to the OR or maybe try and do some neoadjuvant before that. That's it.